All right, good afternoon, everybody. Welcome to SEVA VentRounds. Today is June 27th, 2023. And today we're going to talk a little bit about cycle with this case that was taken actually by Ariel Garnero. He doesn't know I have it, but I have it, Ariel. You didn't know. I downloaded it from one of the ventilators that we were working yesterday. And so disclosures, we discuss particulars of ventilator modes. There's no endorsement of any particular mode, manufacturer, or company. We're equal critics of any ventilator available in the market. Whatever we say, it's our opinion. It does not represent the Cleveland Clinic. I'm Eduardo Mireles, and you see Rob Chatburn on the screen saying hi. And also Ariel Garnero is joining us today, so this is fabulous. And we do have conflicts of interest with stuff that we talk about, but we're very clear on what we say. So the ground rules, this is a recorded session, so keep your microphone muted. I may call upon members of the audience to comment, and if you want to comment something, put it on the chat. And if you want me to call upon you, I will certainly do so. This is one of those things in which the more we speak, the more we learn. There's so many of these SEVA VentRounds that we have learned together and actually written papers after these interactions. There are CME for the CCF staff that are joining, so just wait until the end. There is a little code that will come out. And then there's also CRC for our RTs all throughout the US that are joining us. So if you're a respiratory therapist, please enter the name in the chat to verify that you exist. And then the evaluation must be completed to receive credit within an hour after we are done with this presentation. So we'll start with a very basic understanding of synchrony in terms of cycle. And cycle refers to the end of the breath. So when the breath ends, how does it end? And on this graph in the center, you have what we would call the PMOS graph, or if you had an esophageal catheter, this would be the esophageal pressure as it's depicted usually as it drops the pressure inside the thorax, and when it starts to drop. That's the beginning of the breath, and then usually the end of the breath is close to the nadir, or the end, or the biggest drop in the pressure that you will have on the pressure waveform, and so which is depicted here by this gray line, assuming that there's still some activity and then it ends. And then you can see that actually on this graph we put another dashed line for the end of the mechanical breath. So here you can see the breath started, and actually instead of this nice exponential decay that you would have if this was a passive breath, you can see how all this area under this deformation that you have, sorry, this thing is sabotaging me. All this area that you have over here is representing PMOS, or activity of the respiratory muscles, and you can see that the respiratory muscle pressure they end up around here, and then there's this period where there's a pause, and this is classic for what we call late, and so the patient is activity, the PMOS has ended, and so the breath ended later than what the patient did. So that's why it's called, remember, everything's in reference to the patient. So the breath ends later, the mechanical breath ends later. So it's a late cycle. So the machine cycled later. And on the other one, you have, again, these waveforms. Here you see the end of the PMOS right here around that area. And then the end of the mechanical breath over here, and you see it delineated by this dashed line too. You can see the presence of PMOS again, and there's still PMOS actually as the breath ends, the mechanical breath ends, and that's classically seen by the absence of the peak on the expiratory flow, which actually now I realize I should have put on this picture. So the absence of all that peak here is because the waveform is approaching the baseline, so it tells us that there was still PMOS. So the machine cycled earlier in relation to the end of the breath of the patient, so early cycle. Rob, comments?
Yeah, on the middle one that says late, in
Yes.
between those two gray lines, if you look on the flow waveform, you see there's a little period of zero flow. That represents an occlusion of the airway, and that's dependent on the ventilator that you're using. Servos will do that because it won't let the patient exhale unless they forcibly generate 3 centimeters of water pressure. You don't see that on something like a Draeger. The Draeger will let them freely exhale as they're relaxing. So you get a little expiratory thing and then a big expiratory thing when the ventilator cycles off. The 840 will not let you exhale at all unless you hit the high pressure alarm. So it's highly ventilator dependent.
Yeah, so the behavior may show you what I get from this is either you see a plateau or you see the flow go below the baseline while there's still inspiratory pressure from the machine, correct?
That's exactly right.
Very good. All righty. So that's the basic knowledge that we need to interpret cycling issues as we're looking at the ventilator. So let's go into our waveform, and I'm going to show you a waveform, and it's not pretty. So I'm sorry, but here it goes. So I'm going to let you watch it for a little bit. If you are watching this in the future in a recording, this is the moment to put a pause and look at it and try to interpret the waveform. And we put all the data that you, I mean, I took a full screenshot. Well, partially full screenshot. Alrighty. So let's, if you have any input on what you think this is, enter in the chat the tag, your load, and then any patient ventilator discordance that you see. And we're gonna go in order with this one. So I'm gonna start by talking a little bit about the tag. So anybody has an idea what tag is this one? Put it on the chat. Have no fear. And I put the mode here, and I'll recall for all of you that there's different ways to get to the tag. One is by reading the waveforms. The other one is by using one of the apps the app that was created, the Vent Mode app. The other one is to use one of our, in several of our articles, there's what we call the mode maps or Rosetta cards that have all the modes available. So really good. Many of you have recognized this as pressure control, IMB 2SS. And that's fantastic. So I'm gonna dissect this a little bit. Actually, Rob, I will ask you to dissect this. Why the tag for this is PCIMB2SS?
Well, you can't, let me think. I don't think you can tell that it's IMV2 by looking at this chaotic waveform. It's something that you would have to know prior to this by looking at the ventilator mode map or any of the other publications that we have. But what it means is that when you have a set mandatory tidal volume and a mandatory, not in this case, pressure, it's pressure control. So it's a mandatory breath rate that you have set. However, if spontaneous breaths appear at a faster rate, then they will suppress the mandatory breaths. And they will go into pressure support. So that's why the auto mode symbol at the top there says PC switching back and forth with pressure support. So if the patient goes apneic or has a very low spontaneous rate, then you'll get mandatory pressure control breaths. And if their spontaneous rate is higher than that, then they'll be all pressure support breath in this case. So that's what it means, IMV2, spontaneous breaths suppress mandatory breaths. The first S means that all the breaths for the mandatory breaths are set point targeting. That means that you set all the parameters, and the same thing goes for spontaneous breaths, because in this case, they're just pressure support. Is that what you wanted?
Yeah, that's perfect, Rob. So, and a simplistic way of seeing this, it will move from pressure control CMB set point to pressure control CSB set point back and forth, depending on the presence or not of spontaneous breaths, correct?
Yep.
All righty. So that's fabulous. And then the next question that we have to ask ourselves is, well, can we see the load? Is this elastic load, resistive load, or is there so much PMOS during inspiration and expiration that we cannot ascertain this and it's just pure PMOS? So I see a fair amount of people have put that PMOS is actually obscuring the majority, although Sai mentions there's inspiratory PMOS, but the expiratory load is a combination of resistive and PMOS. So let's just look at the inspiration for a second, and you have several breaths occurring over here, and it's a large amount of them, and all of them have different inspiratory times, and that goes along with that this is behaving right now as pressure support. It's a PCIMB, but these are all spontaneous breaths, pressure control CSB breaths or continuous spontaneous. So that's why all the I time is different in all of them. And you see, what you're looking is at the exponential decay, and really you don't see any of them with a nice, beautiful exponential decay. And I'll just go, this is what we're looking for, this beautiful exponential decay that you have here or here on this dashed line. And instead of that, you see all of them have either straight or aberrant. And so I cannot read the inspiration. So definitely PMOS during inspiration. And then during expiration, you try to see through them. You see one expiration here, one little one here, another one with a lot of aberrancies that there's effort there, perhaps a little bit of exponential, but so it's very hard for me to read this, and I would say that this is all obscured by PMOS. Rob, do you have any disagreement there?
No, that totally agree.
Yeah, it's pretty messed up. So PMOS, I cannot necessarily read through this. And I would advise, just for the sake of the people here, that when you see the seeding, the compliance, the dynamic compliance here on somebody that has so much PMOS, you should essentially ignore this value that it's right here, because it's a manifestation of the PMOS of the patient. So with that, it's all PMOS. So let's go to the PV discordance now. So let's start by trigger. And we have all of the breaths are triggered, and they're being triggered by flow, as you see, because it's changing color here. It's where the marker is. So what do we think about the trigger? Normal, early, late, false, or failed? And just type it on the chat. I see one answer coming in. All right, I know that sometimes it's challenging to watch and through the phone and type at the same time. There you go, a couple more. Yeah, I think that this is normal. If you see all the breaths, you can see that this is definitely triggered by the patient. You see the drop in pressure before the breath, not major delay. Although I would say whenever you have this, if you see this too small, you should change the gain so that you can see much better the waveforms. I mean, in this ventilator you can adjust the gain or make it automatic so that it looks very nicely. So unfortunately, on these curves, Ariel, very poor gain. So, but I think that this is normal, that they are being triggered by the patient effort. That's how I would read it. So I would say normal. What about inspiration? And during inspiration, the question is this normal? Is this over-assisted? Or is this under-assisted? Or meaning that there is severe work shifting? Actually, I have to correct this. But So the pressure is not dropping below the baseline in any of the breaths. So I would say that's not under assistance, at least. There is, and then over assistance, you can see that every breath is getting some assistance, but there is no evidence of very small PMOS. So I would say that this probably is, there's work shifting, but I would say that the assistance level probably normal. Rob?
Yeah, I have to agree.
Okay. And then comes the cycle. So what do the team feels about the cycle? So I see that the answers starting to come in, and the majority of the team is feeling that this is early, and that is correct. I think that you have to see the pattern that you have is every single breath is activated by a patient signal, which would be a different read if it was not that the case, if you had mandatory followed by patient. But in this case, you have evidence of PMOS at the beginning, so triggering the first breath, and then triggering the second breath. There is some signal towards the second breath being triggered by the patient. So I think that this would be early, and how we would read this is that you have the patient and the PMOS, if I could draw it in length, is lasting this amount of time. So it's a long PMOS. The neural's inspiratory time is longer. Longer than what the machine is delivering in this case. And you see this one didn't happen. In here, the patient inhaled and exhaled actively without having that problem. But here, the patient definitely had that occur. And then expiration, there is evidence of expiratory work, as we discussed earlier. And this is important that you see this, because you now recognize in this patient on pressure control IMB2SS, where there's a lot of PMOS, that the patient is having early cycle, but the patient is on pressure support CPAP. So, and yeah, thank you for putting that, Rob. This is causing double trigger. And remember, this is a common source of confusion in the literature that we call double a dyssynchrony of sorts, but it's actually a pattern with several etiologies. And in this case, the etiology for this double trigger that you see here is the presence of early cycle. So I see. So how would the team solve this problem? So I see one option is, well, let's increase the flow, after which it cycles. So giving more flow. So that one option would be to increase the pressure support, is what I'm seeing here. Increase the I time. So that's another option. And so when you're in pressure support, there's not a set I time. You have to adjust it, right? And so somebody's starting to talk about increasing the expiratory threshold for the cycle threshold. So I'm going to show you now that this is those are excellent. Now I have added to the screen. So you had here the waveform that we were working on, and I've added this waveform just for the sake of learning, and it's the same patient, but now we have added the settings for the patient. So now you can see what was happening. And again, you see now in a more cleaner version, you can see the presence of the double trigger pattern that is consistent with early cycle. And you see here the cycling threshold is set at a percentage of the peak inspiratory flow, percentage of the peak inspiratory flow. And you see that it's cycling at that level. And then there's this little tiny effort that comes afterwards. And actually, this one is a beautiful waveform because it proves the point, is that the patient was doing effort, continues to do effort, but now doesn't trigger the next breath. So in reality, this should have looked something like that, but the patient was doing effort there, and led in this one to a very classic image of an early trigger. And so if you see the settings, the patient was on this amount of oxygen, so a very little amount of PEEP, very little amount of pressure support. And then this is the end inspiration. This is the cycle threshold. And I know ventilators call it very different things according to what you're seeing. There, Rob puts the expiratory, the ETS or expiratory trigger sensitivity. There's all these different terms that are used. PIF percent. It's pretty confusing. So here the end inspiration was set at 30% on this patient model, and it was leading to a early trigger because the end inspiration, although usually this may be okay, for this patient under these circumstances was too little or too high, and it was leading to early cycle. Rob?
Exactly.
Okay. So the action is to change that. And so the astute RT at the bedside changed the inspiration to now a 10%, so 10% of the peak. And you can see how that has made the problem disappear for this patient. And now you actually can see much better the expiratory phase for the patient. There's still, this one had a little bit of an early cycle, but the majority of them have improved. And so good job on adjusting these ventilator settings. So here's the before, and here's the after for this patient. You can see the amount of wasted effort that the patient was having improved, right? So now it's getting support throughout the breath. And so I mean, when you think about early cycle, that leads to a degree of under assistance that the patient is having, meaning that the patient is not getting support at the end of the breath. But this is, and you probably can see it a little bit better here, how the pressure is down, the patient is still doing effort and not getting what the patient needs. So important observation. Yeah, so this plays that closer to the patient's neural inspiratory time, better synchrony. I think that the rate is falsely decreased here, so you see 60 now, but that is because the ventilator is counting every single one of these little suckers here, and that is not, those are being extra counted by the ventilator. And if you see in the one prior, it was even counting more of them. So that's a good teaching case for the end inspiratory threshold, cycle threshold, and expiratory trigger sensitivity and how to adjust it. I'll see if there's any comments or questions from the audience. Any comments, anger management? Now, the clinical significance of this is, I mean, to be defined, but I presume that this is not comfortable for our patients as they're going through it. A common other question that I get, I like to pose to the teams is when you have double trigger in this case, if you had to rank them from evil to better, so or less evil, so you would have volume control, sorry, CMB S, PC, CMB S, PC, CMB A, and pressure control CSB S. Which one would be the least harmful and which would be the most harmful, least or most? So one of the questions is what if we change the patient to PCCSB? Well, that the patient was on PCCSB, the Mohammed. That's exactly what the patient is on. Even though the mode says auto mode, the patient is essentially breathing right now on pressure support. So so double trigger can occur on pressure PCCSBS when you set the end inspiratory threshold too short. So if you had to choose one mode, which would be the worst? So yeah, CMBS is the worst. So this one we're gonna put like the most evil, right? Like because you get double. And then what would be the next most evil? This is a good exercise on breath on thinking about these things. So remember, if the difference between PCC-MBS and PCC-MBA is that they are adjusting the trigger, the pressure, in PCC-MBA, it will adjust the inspiratory pressure to try uh, to target the tidal volume. So I think that the most likely PCC-MBA in somebody that is actively breathing will have less pressure than PCC-MBS because of the work shifting that would occur. So I would put the second as baddest, this one. So I would put this one the worst, this one the second worst, sorry, second worst, third worst, but these are pretty tight. And the least one would be this one or NAVA. That's how I would think about it. Rob?
I agree.
Okay. So there's what type of patients do you see needing a lower E sense on a routine basis? That's a great question, Josh. And I would ask the audience to put there which patients do you actually use lower E sense? In my practice, I do that for a couple of patients. The patients that have a very low time constant. Sometimes this may lead them to cycle very early and dropping their mean airway pressure. So I tend to, in those patients with a very low time constant, I tend to decrease my end inspiratory threshold as low as I can, which may be the case for cirrhosis, as Jay is putting in the comments, meaning unless there's another indication that you're thinking about, Jay, that we need to think about. But that's what I would think. And then on the patients that have obstructive lung disease, then on those patients we go up on on this threshold, because those patients, if you try to go very low, they will continue to, I mean, the time constant is so prolonged that they may take forever to exhale, to inhale and to cycle around. Sai asked about patients with neuromuscular weakness. If they have very low, so very low compliance or high elastance, yes, then I would think about dropping it, Sai. Another question here is, and also leaks around the cough or chest tubes with higher peak the higher cycle threshold. And can you explain a little bit more about that, Ariel?
Yes, usually when you have a leak, it takes a long time for the flow to decrease to the cycle criteria. So you have to find a way to usually end the breath earlier. When you have a chest tube, it's the same thing. Even sometimes you have to choose using time instead.
Yeah, or those would be patients that if I mean you have somebody with a high BPF, that you may want something different to trigger or cycle the breath, like NAVA perhaps would be better under those circumstances. I see, yeah, Miguel, you put COVID, those patients with very low elastance, sorry, compliance would be an issue. For all the CCF caregivers, here's the code for the CMEs. This comes included, and for all of those that are RTs, I know Ryan is going to post right now the link, and you can also scan this QR code that will get you there. Please have no fear. This is free and it's all for you. Really very, very educative session. Thank you very much for joining. It's great to see a lot of friends from Mexico joining too, from around the world. Hara, thank you for joining us. And a lot of our staff and our fellows are also aligned and really moving along. And Argentina, there you go, Lorenzo. Woohoo! Thank you all for joining, and we'll see you in 2 weeks in our next environment. Thank you.